Well, I see who the early birds are. Can you all hear me okay? Anybody?
Yes.
Brilliant. We're going to give everybody else just a couple more minutes and then we'll jump into it. And if not, we'll just have a very small review together.
Okay.
All right, everyone. We'll let others trickle in as they want to give in. I am not used to giving meetings by teams, so I'm sure there's going to be a couple mess ups. But the first thing I want to do is share a screen here. Can you guys see my screen?
Yes, I can see it.
All right. Can you guys see the PowerPoint?
Yes.
All right, brilliant. So when I'm in this mode, I really can't see any of the comments or anything. So if you have a comment or a question, write it down. We'll circle back at the end. First off, thanks for being here. I tried to do my best with hitting the challenging areas. If I haven't covered it in this and you have a question after the fact, I'm really going to be looking at the discussion board over the next few days. So feel free to post and I'll continue answering those questions. But let's jump into this. A couple things I really want you to think about. I didn't do any of this in any particular order, so it's not per test or anything like that. Just because in case we ran out of time, I wanted to make sure I touched upon everything. All right, so when I've been dealing with a couple of the students just with tutoring, there's a couple things that I've noticed. The first off is make sure you read the question, make sure you understand what the question is asking you. If you can, at that point, think about the normal physiology of what's supposed to happen. And then at that point, try and come up with the answer. A lot of people, they can't at that point, but sometimes if you can come up with the answer at that point, it's less confusing before you even look at the other answers. Now, once you think about the normal physiology, then start thinking about the pathophys. What is abnormal in this situation, and why is it abnormal? This is going to be really, really helpful for you, especially when it comes to thinking about hormones, especially when it comes to thinking about, in my opinion, when it comes to like the heart and some of the other things that we talk about. Because if you know your physiology, it's a lot easier to understand when things go awry. All right, so the first one that I wanted to tackle was mechanisms of action regarding telomerase. Now, if you'll recall from your lectures, telomeres are the very end of genetic material at the chromosome level. So every time a cell, a somatic cell specifically, so dividing cells, every time one of those divides, the telomeres get a little bit shorter and a little bit shorter. When you run out of telomeres, that means that your cell is no longer capable of dividing. Now, this is a built-in way we age. So a couple things to think about. In the past, we used to think telomeres had no purpose. I'm glad we have found a purpose now. But what they do is they use an enzyme called reverse RNA. And what that does is that takes RNA and it builds TMA. So telomerase builds TNA. So what it is doing is as your telomeres are getting shorter and shorter and shorter, the telomerase actually rebuilds those a little bit. So it builds those end caps up a little bit and allows for some continued cell division. Now, they are available in all somatic cells to a small level, and that's the way it should be. When they occur in larger levels, that's when we end up having cancer. So what they do is they rebuild the DNA, and as they do that, they make the telomere longer. That allows it to keep dividing. But if that happens too frequently, too much, that's when a cancer gene has been turned on, and that leads to prolific cell division. All right, let's jump on to a new one. Another one that students had trouble with was just completely understanding a cellular dysplasia. So a couple things to remember about this. The key point is it is not definitively cancer. This is the presence of abnormal cells within a tissue or organ that have changed over time. So they are considered precancerous. They may not progress to cancer, but they have changed enough that it should be concerning. And usually what we do, especially in the example of doing pap smears, when we see dysplasic cells, is sometimes we just go in and we ablate that tissue, we remove that tissue, burn that tissue off in order to prevent the possibility of it evolving into a cancer type situation. So they're abnormal. They don't mean, it doesn't mean that they're cancerous, but it does mean that there is the likelihood of it. These are going to occur more often where you have rapid cell division. So think about your mucosal tissue that divides much more frequently than some of your other tissue. Now, big areas that people got very nervous about were the cardiac system, and I fully appreciate that. Let's break it down into a couple different components. So I wanted to talk specifically about ventricular hypertrophy, and that's where the ventricles of the heart So the larger areas of the heart start to get abnormally large. There's a pathologic increase into that mass. Now, what happens there is, if you can see where my cursor is, on this left side, so this is the left ventricle by LV here. As this gets bigger, it not only gets bigger in the outward direction, it gets bigger in the inward direction too, which decreases the size of the left ventricle, which means less blood can go into that left ventricle, which means that when your heart squeezes and you have a contraction, less blood will go out the aorta. That means you have a decreased stroke volume. So if you have a decreased stroke volume, that's your cardiac output, okay, then your heart is going to have to beat faster to make sure that your blood is perfused or your body's perfused. So one of the symptoms of left ventricular hypertrophy may be a tachycardia rhythm as your body tries to compensate for that inability to get that good stroke volume. All right, but one of the things that I wanted you to look at first was, if you'll notice on this left side, this diagram, the muscle on the left ventricle is thicker. And then if you look on this side, the muscle of the right ventricle is thinner. Well, the reason for that is the right ventricle only has to put blood through the pulmonary arteries to the lungs. So it doesn't have to push it that far. You don't need a big old heavy muscle to be able to do that. From a pathophysiology standpoint, that puts this muscle at a lot more risk to get really dilated and stretched out if we have a heart failure type situation. Whereas this one's pretty strong, it's less likely to get dilated. It will in extreme situations, but I want you to think about the normal first. The reason this has a much larger, thicker tissue base is because not only does it have to go through the aorta, it's going all the way out to all of your body systems. So you do need a stronger oomph of a push to get it to exit the body. So if you think about a few things, just staying on this screen and not thinking about hypertrophy at all, if you think about afterload in this particular situation, afterload for the left ventricle would be the pressure it has to overcome going through the aortic valve, as well as any pressure it has to overcome going to the rest of the body. Think about high blood pressure. We'll talk about that a little bit. Same thing on the RV side. All right, afterload for the right ventricle is going to be back pressure either from the pulmonary valve, which that little guy tends to do incredibly well with functioning normally. But then if you have pulmonary edema, a PE, sclerosed lungs, pulmonary arterial hypertension, any of those things, that would be the type of afterload that your RV would have to deal with. All right, so specifically talking about right ventricular hypertrophy. So the majority of the cause is going to be pulmonary hypertension in the lungs. You may or may not have any of the left heart involvement. Sometimes when there's left heart involvement, the failure actually started with the left heart. It backed up into the lungs, increased the pressure backwards towards the right ventricle. But the majority of the time, it's going to be pulmonary hypertension. But there are some other things that can cause this. Anything that could affect your tricuspid valve, which is going to be this valve here, can also affect the right ventricular hypertrophy. Because if you think, when the sides of the RV push, okay, they don't just push in this direction that the arrow is going into. That makes too much sense. That's way too easy. It also pushes up against the tricuspid valve. So if you have a leaky tricuspid valve, then you also have you also have blood that's leaking from the right atria into the right ventricle at the same time that the right ventricle is trying to push out. So then it has a higher back pressure here. And what happens when you have back pressure? It's just like building muscle. So this muscle starts to get thicker and thicker and thicker, and that's where you get that hypertrophy. This can also happen because of cardiac surgery. Sometimes with cardiac surgery, that messes up the tricuspid valve and causes that backflow. It can also be a genetic thing. Okay, left ventricular hypertrophy is something that we see a lot in the ICU. Now, as I referred to just a little bit ago, it's caused by that left ventricular muscle being used a little bit more than normal. So it has to overcome two types of afterload. Static afterload, which means the static back pressure against it, is going to be caused by possibly aortic stenosis. That can happen with calcified valves, especially as we get older, but it's a pressure that it has to overcome. Or it can be dynamic afterload, which is resisting against high blood pressure. And so just like I said in the previous slide, the heart muscle is having to push against a higher pressure that's causing a back pressure. And by the nature of how our muscles develop, it's just going to get bigger and bigger. And again, it's going to build inward to decrease the size of the left ventricle, but it's also going to build outward too. So you're going to decrease the amount of blood that you have in there that you can squeeze out, which kind of gets worse and worse and worse because you also have this back pressure here. So not a lot of blood's going to be making it to the rest of the body. These patients are not going to feel great. Now, the other time that we deal with left ventricular hypertrophy is this thing called HOCM, hypertrophic obstructive cardiomyopathy. And I put this picture over here specifically because I wanted to impress upon you how this is pretty dramatic on the heart. So this would be what a normal heart looks like. Remember, you've got the thin muscle layer over here. You've got the thicker left ventricle muscle over here. This will be the septal wall in between. HOCM, as we call it, hypertrophic obstructive cardiomyopathy, is a genetic disorder. And what happens is the muscle fills in on both sides. It's not necessarily related to a valve problem like the aortic stenosis. It's not necessarily related to a high blood pressure problem because of the afterload situation. It's just that this muscle is getting bigger and bigger and bigger, which is decreasing the amount of blood you can fit in your left ventricle, which decreases the amount of blood that you can push out to the rest of your body. So one of the things that we can do from a surgical standpoint is what we call a septal myectomy. And so the surgeons go in, and if you'll see right here where my cursor is, that's right where the aortic valve is. So if this gets too big, it can actually move the aortic valve, push it a little bit out of sync. So it doesn't always close properly. It doesn't always open properly. That's called an outflow problem. But what they do is they come in here and they actually shave some of the muscle here. And the idea is to create a bigger ventricle so you can get a bigger stroke volume so you can improve your cardiac output. So like I said, always go back to the beginning. What's the normal physiology and why is this different? And this is where you start wishing you'd paid better attention back in A&P the first time, but it does start to click after a while, I promise. Okay, switching gears. Everybody gets a little bit mixed up when it comes to bacterial colonization. So it's really straightforward. It's the presence of bacteria on any of your body surfaces, and we all have it. We all have different flora depending on who we are, the antibiotics we've been exposed to, how we live, all kinds of different things. I can't imagine what us as nurses have all over our body as compared to the normal layperson. But the key thing is that this is our normal flora and we don't get infected from it. So if somebody is colonized with a particular bacteria, it means that they don't normally get infected by that colonization. There's usually nothing to do. Now, when people are at higher risk for infection, sometimes that shifts just a little bit, especially if they're immunocompromised. So in very, very specific circumstances, what we do what's called decolonization. And so, for example, if you are putting hardware into somebody's spine, a lot of times we'll do MRSA decolonization. So that just means that we put Bactroban on somebody's NURS twice a day for 5 days. The hope is if they have MRSA bacteria as part of a colony in their own NURS, normally doesn't cause them any problems, but now you undergo this surgery and they can literally become inoculated with that bacteria and it causes a post-surgical infection. We want to avoid that, so we decolonize. But bacterial colonization, normal thing. The patient usually does not get sick from it. It's not something that we worry about, except for in certain circumstances. Now, bacteria translocation is something else I wanted to touch upon. So normally our gut does an amazing job of keeping the bacteria exactly where it needs to be, and that's inside the gastric mucosal. The problem is when we have situations where we either have a bacterial overgrowth or we have an immune deficiency problem, or for some other reason we have increased permeability of that intestinal mucosal layer, and that allows bacteria to sneak in between the villi, and they go to the lymph nodes, they go into the tissue, or they go into the bloodstream, causing bacteremia. Well, what are the situations that we find ourselves in with this? As I mentioned just a second ago, when we have deficiencies in our immune system, that can be our neutropenic patients who are undergoing chemotherapy or things like that, people with immune deficiencies such as someone HIV/AIDS, or honestly, when we are going through great periods of physiologic stress, sometimes even chronic stress, but this is a little extreme for chronic stress, but acute physiologic stress, such as states of shock. People are at higher risk for bacteremia, and one of the reasons that they are higher risk for bacteremia is because their immune system is actually suppressed during times of shock, and that creates the perfect environment for bacterial translocation. So again, the bacteria are supposed to be in the intestinal gut, and it goes through the villi and goes where it shouldn't be, into a normally sterile environment such as the blood, the lymph nodes, or the tissues. I'm going to stop before I go on. Any questions so far? Okay. I also wanted to just kind of touch upon afferent versus efferent blood flow in the kidneys. This was not on one of the challenging areas list that I was given, but I have found it to be an area that students tend to struggle with. So the way that I remember this, and you're going to need to know this for several different things. One, how our kidneys filter things and disruptions that occur there. But also, we use a lot of medications that actually directly affect these areas of the kidney. So the way I remember it is afferent arterioles deliver blood to the kidney. So it's coming from outside the body, gets delivered by afferent, and then it leaves via the exit, which is the efferent, on its way out. So E for exit, and then I always remember A comes before E because the afferent arterioles have to get the blood there. I don't know about you, but little tiny tricks like that just kind of help me remember things. So hopefully I can help you out with little things like that. And one of the other areas was causes for chest wall restriction. So always consider chest wall restriction. Of the things that's included in that is it's a pulmonary process. Okay, there is a reason that you can't fully expand your lungs to take a good breath. Now there are multiple reasons for that. We'll talk about a few of those, but just remember if you hear chest wall restriction, always think pulmonary restrictive, where you cannot get enough air in. Now some of it is due to structural changes, as you can see on the pictures that I put up here, scoliosis to a varying degree, depending on where the curvature of the spine is, as well as the associated rib changes that occur with that, can shove your lungs over. It can also shove your lungs up. Remember, if you think about normal anatomy, if you're standing in front of a mirror, you've got the front of your lungs that come down to about the end of your rib cage, but in the back, your lungs actually extend down a little bit further. So if you've got somebody who is really bent over, especially in the lumbar and the thoraco-abdominal region, they're not getting any expansion of their lower lungs. So that can also be a chest wall restriction. But literally, the skeletal system is not allowing those lungs to get a full expansion. So kyphosis kind of makes sense. Scoliosis kind of makes sense. But what about muscular dystrophy and obesity? So these aren't obviously structural issues. Muscular dystrophy occurs at the cellular level, but the reason it's considered under the umbrella of chest wall restriction is because the dystrophy creates a muscular weakness, and the muscular weakness prohibits you from taking in that full breath. It prohibits you from dropping your diaphragm all the way down and getting that full breath in, as well as your intercostal muscles and any of the other muscles that you use. If you think about somebody with retractions, how they use the muscles underneath their clavicles, they even use some of their throat muscles if they're in respiratory distress. Obesity is kind of along the same lines. Your lungs are still protected by the rib cage, but if you're carrying around a whole bunch of weight, especially upper body adipose tissue, your muscles are still having to overcome all of that weight with each breath it takes. And that's why you get things that occur over time, such as obesity hypoventilation syndrome and things like that. Now, that's an oversimplification, but if I took a 30-pound weight, okay, and I was laying flat on the ground and I took a 30-pound weight and I put it on my chest and I tried to expand my chest, it would be much more difficult for me to do that. Somebody who is obese has a gradual increase in their weight most of the time, has a gradual increase in their weight over time. So they do develop some compensatory mechanisms, but at some point they can plateau and they just cannot take those big breaths without exhibiting a lot more energy that's associated with it. But circling back, I want you to take a look at those 3D images of those lungs and how that they're affected, and why they wouldn't get full expansion. Okay, let's talk about strokes. I'm gonna include strokes and TIAs kind of together, but there's a couple things that I wanted to point out specifically to TIAs. If you recall, transischemic attacks are something that where the symptoms usually resolve within 24 hours. And I don't mean just resolve a little bit, the symptoms are resolved. That's the criteria. And so those are usually due to some sort of hypoperfusion that somehow resolves. So a lot of times when people come in with TIAs, one of the things that we do consider is looking at their carotids. Because if you think about the average American, especially since we tend to have an epidemic of obesity and we don't have the best of diets, we have a lot of atherosclerosis in our population. And so it doesn't just affect the heart, it's going to affect all vessels of the body. And so one of the bodies that we think about, um, especially when it comes to TIAs, as well as strokes, is what do the carotids look like? Now, if you'll notice on this person, their carotids are nice and thick, which means there's very little blood going through. So if there were to be a small plaque rupture or even a small clot that disrupted that, even for a short period of time, the patient would have symptoms downstream. There are times that we have people that actually occlude their carotid arteries, and that actually can cause very, very large strokes throughout. But what are some of the etiologies of strokes? So large artery atherothrombosis. So you've got a clot, or you have a diseased area here of plaque. And when that plaque disrupts for whatever reason, that causes a cascade of platelets and fibrin to go to that area and form a clot as a normal pathway for repair. But what often happens is that breaks loose. So if you have an area that you have a clot in that is stationary, that's a thrombus, right? Well, once that clot breaks loose, that becomes an embolus. And so that travels downstream, and then it occludes. Once it gets to a smaller and smaller vessel, once it gets to a vessel that it is too big to go through, it completely occludes that vessel. That means blood is not going beyond that vessel, which means that the tissue beyond that vessel is being starved for oxygen and will die. So large atherothrombosis usually affects large vessels when it comes to strokes. I'll explain that a little bit more in a second. Now, small vessel disease, you see this much more in hypertensive people as well as diabetics. Now, that doesn't mean that they can't have a large stroke. What it means is that where the infarct is, where the occlusion is, where the blood flow is not getting beyond, it means it's in just a smaller vessel. That means that it's less likely to respond to us going in and being able to grab it and move that clot out, which is called a thrombectomy. Patients with small vessel disease, if they present in time, which time is tissue, if they present in time, sometimes these are the people that are candidates for TPA or lytics that will break up that clot. But again, a lot of times small vessel disease is associated with people who are diabetics, as well as people who have a lot of hypertension. Now, another etiology of strokes is cardiac embolism. So if you go back to the heart, if you think about the left atrial appendage, which is kind of that flappy little thing on the base of the heart over the left atrium, that actually tends to be where most of our embolic strokes come from. Remember, embolic is something that has been moving through the bloodstream. So that's an area where the blood is very turbulent, and with it, it can actually get into like almost an eddy, if you think about a river, and it can form a clot. And from there, it gets dislodged and it goes straight up the carotids into the cerebral blood supply. Now, you only have a few points of access for your blood supply for your arteries, so of your brain. So we have anterior access. That's the MCA, the ACA that you guys were studying, and then you have posterior access, which is way back by your vertebral arteries. The stuff that's coming from the cardiac embolism is most likely going to affect your anterior circulation. So that's going to be an ACA stroke, an MCA stroke. But that is, again, a moving clot that has gone up the carotids and keeps going until it finds a break or bifurcation in the vessel that is so small it can't pass through. At that point, the tissue beyond is in danger. Now, what's really cool for those of us that are older is that we oftentimes have a little bit of collateral circulation. And so we have little side streets where some blood can possibly get beyond that occlusion. If a stroke were to happen in somebody who is younger, say in their 30s, which yes, that does happen, they don't have that collateral circulation, so they are actually at higher risk for having a more devastating stroke, because when they have that occlusion, no blood is getting beyond where it needs to go, and the tissue infarcts. Cryptogenic is just kind of a fancy word for saying there's an embolic stroke. We don't know where it came from. So when that happens in the hospital, we start looking at other places. So, somebody will get a CT when they first come in, and then we followed up with an MRI, and the MRI just kind of helps us define the stroke territory that's been looked at. They also get an EKG. On the EKG, we're looking to see if they have AFib, because if you remember, if somebody has AFib, they're much more likely to have a clot. We also do an echocardiogram. The echocardiogram is looking for, is there a clot in the left atrial appendage? Is there some other clot that's in the heart? Because if you remember, let me go back a few places over here. When blood is stagnant anywhere in the body, it's more likely to form a clot. So if you have something like this, where you're not moving a lot of blood out into the system, you're actually at higher risk for forming a clot and giving yourself a stroke. We also tend to do carotid duplexes to look to see if it came from there. We also consider, is it sepsis? Do they have endocarditis? And there's little bits of bacteria plaque that are being showered up into the brain. Now, there are some other reasons that we can have strokes or TIAs, and those really weren't covered by our material, but I just wanted to touch on them a little bit. One of them can be a hypercoagulable state. So if somebody comes in with stroke multiple times, we start thinking, okay, is there a genetic problem? Is there a reason that they are having higher likelihood for strokes? And then we go look for that. Arterial dissections are a very common way to have a stroke. So one of these ways that you can have them is going to a chiropractor. I'm not saying don't go to chiropractors, but if you think about the high velocity neck movement that occurs when they sometimes crack your neck, there is a vertebral artery that comes out from your high level vertebra and then goes right back into where the brainstem is. And between that type of high velocity move, as well as the type of movement that we sometimes get when we're on roller coasters, that can actually cause vertebral artery dissections. And when you have a dissection like that, that is also a time where the platelets and fibrinogen in the cascade is going to form a clot, and then that clot can embolize and cause a stroke downstream. So when you think about strokes, especially as you're studying for strokes, and you will see strokes again and again and again, not only throughout school, but as you go on to your careers, think about the vasculature of the brain. Get comfortable with that, and then remember that the symptoms are related to the area of the brain that's not getting the blood supply. About 90% of our strokes are ischemic, whereas 10% are due to brain bleeds. And then I did have a couple students ask me, well, what are lacunar strokes? Lacunar strokes happen a little bit deeper in the brain. They tend to be small vessel strokes. That doesn't mean that they are not highly dangerous and highly debilitating strokes. It all depends on where the vessel is that's affected. So if it affects the thalamus or the basal ganglia or something of that sort, that's some pretty high value real estate and can cause some pretty devastating effects. I didn't want to spend the time in this review going through stroke symptoms and what was associated with what area of the brain, but do take some time doing that. I also was fortunate enough to take this particular picture the other day. This is somebody who is in a angio suite, so they're having dye injected up into their brain, and if you go right up here, all of this is the brain tissue that is being supplied. And this is, by the way, this is a 2D image of a 3D brain, obviously. This is dye that's only been shot into one side of the brain, not both. But you get an idea, which is why we have collateral circulation. Anyway, this is the area that is fed by the ACA. So the anterior circulating circulation is up here. And then back here, it gives you a good idea of vessels that you've got in the posterior part of your brain and posterior cortex. We're not talking about the brainstem or anything down here. But you see this gap that's right here. So this person has a very large occlusion in the middle cerebral artery. And so you see what a huge vascular territory this person is not getting perfused because of that occlusion. And if you look at all these tiny little threads here, you'll see that was the collateral circulation that I was talking about. So they are getting the tiniest amount of collateral circulation, but the middle cerebral artery territory is almost completely wiped out. So as you study that, think about, okay, this is the blood supply. Everything beyond where this blood supply goes, that's what's in danger, and that whatever that area of the brain does is the symptoms that you're going to see knocked out, and that's how that person is going to present with their stroke-like symptoms. Now, I wanted to touch about hydrocephalus. Hydrocephalus is when we have too much cerebral spinal fluid in our brain. Now, it can affect us as kids, it can affect us as an adult. Usually as kids, it's something that we tend to catch pretty easy. But signs of hydrocephalus are going to be headache. I'm going to assume that wasn't for me. Anyway, signs are going to be headache, blurred vision with a fixed downward gaze, if you'll see right there, and that just has to do with where the pressure is on the nerves. Patients can have nausea and vomiting, and by nausea and vomiting, I don't mean I feel a little ill and I'm gonna yak into my pretty little kidney-shaped emesis basin. These patients have very high intracranial pressure with the hydrocephalus, and so when they do vomit, it is the type of vomit that will paint the walls. So I know this population when it comes to adults, not so much as children, but the symptoms should be about the same. But why don't adults get these big old honker heads? Well, the reason is because we have all of our sutures on our skulls closed. And so kids have, I don't want to say the luxury because that's not the right word, but kids have a compensatory mechanism because their sutures aren't closed, their heads can actually expand. And so the pressure goes upwards. For adults, when this happens to us, our skulls can't expand. And so the pressure actually starts building in a different direction. And we tend to actually herniate downward through the foramen magnum. And then for us, that's usually a game over situation. But what other things do we see? Problems with balance and coordination. And then we also see lethargy and altered mental status. I'm going to circle back and talk about that just a little bit more. So what is it? We have this system. We create about 20 ml of cerebral spinal fluid, 10 to 20 ml per hour. It bathes our entire spinal system, our spinal column and nervous system in its tissue. So it goes around our brain, it goes down our spinal column, it acts as a barrier, it acts to transport nutrients and other things. And once it's done its circulating pathway, it's supposed to go through the third and then the fourth ventricle, and then it gets reabsorbed into the system until we make more. Well, with hydrocephalus, something is blocking that, and so you have an abnormal accumulation of that CSF deep within the ventricles of the brain. In children, it's highly associated with spina bifida. So when you see spina bifida, always have that on your radar of do we worry about congenital hydrocephaly? Yes, we do. We also worry about it in both children and adults that have intraventricular hemorrhages, so hemorrhages that are within the ventricles of the brain. And patients who have subarachnoid hemorrhages. This right here is a CT scan of somebody with a subarachnoid hemorrhage. So normally we would expect the CSF fluid to drain through here, and sometimes what happens is the blood actually, blood consists of the plasma as well as the actual cells like the RBCs, and those actually start to settle out of the CSF with the blood, and then it pools down and actually occludes the ventricles where the CSF would drain. I have been impressed as somebody who sees people that comes in to the hospital subarachnoid hemorrhages, because they can go from having a normal conversation to being sleepy to being almost comatose in less than half an hour. So if you have somebody that has a head bleed that you're worried about, that's one of the things that you consider is it hydrocephalus, and what can I do to rectify that? And usually none of us are the ones that rectify that. It's a call into the neurosurgeons. And then eventually what happens is they get a drain that gets put, it goes into the ventricles. It has a certain valve that allows, when the pressure reaches X amount, it escapes the valve, it goes down, and it drops into a drain either in their lungs or a drain into their abdomen. But that's for a different class. All right, diabetic nephropathy. So there is no way that we can get through being nurse practitioners without dealing with diabetics. It's just going to happen. So we need to know what happens with our diabetics, and we also need to be able to explain it to them. But moreover, in this class, we need to be able to recognize it. So, diabetic neuropathy, essentially you are finding albumin, which is a protein, if you will recall. You're finding albumin in somebody's urine on more than one occasion within a 3 to 6 month period. There's a couple things that happens. It leads to or is associated with a decline in the glomerular filtration rate. And it also, because they have that decline in the glomerular filtration rate, they can't pee out as well as somebody with normal kidneys. So they're also at a higher risk for elevated arterial blood pressure because they can't sense it. So what's the problem? Well, you have these high glucose levels, which are also associated with inflammation. And over time, this doesn't happen instantly, but over time, as you are aware, high glucose levels affect the basement membranes of cells. In the eye, it's the retina. In our hearts, it actually has to do with the basement membranes of our vessels. But in the kidney, it has to do with the glomerular basement membrane. So the functioning area of the kidney that works to filter these things, it actually becomes thickened because of inflammation and chronic damage over time. It starts to dysfunction, and as one of the ways it is dysfunctioning is you start to pee out protein, and the protein that we pee out is albumin. All right, let's talk about cardiogenic shock. People mess this up a lot, and I think it's because this particular type of shock is treated differently than some of our other shocks. So let's talk about the normal expectations of the heart. So we expect the heart to produce an adequate blood pressure, and with that adequate blood pressure, we expect that all of our tissues and organs are going to get adequate perfusion. So we need to generate a decent cardiac output. And the way we look at that in the intensive care unit is cardiac index. Since all of us are different sizes, cardiac output is kind of a crude man's way of doing it. But when you take in somebody's body surface area, it gives you a cardiac index. And so we want the blood to get out to the tissues. We want our tissues to be adequately perfused. But in order to have that happen, we need to have an adequate squeeze of our heart. And that's the opposite of what happens in cardiogenic shock. So if you're evaluating somebody with cardiogenic shock, you're going to see the opposite, okay? So you're going to see the non-normal things. So my expectation in a normal heart is I'm going to get a normal pressure or even a high pressure. Well, in somebody with cardiogenic shock, it's going to be a low blood pressure. They're going to have hypoperfusion. How is that going to be demonstrated? Well, literally, if you go up and assess your patient by laying hands on your patient, they're going to be cold, they're going to be clammy, they're not going to be well perfused. Their capillary refill is going to be delayed. And then the cardiac index is going to be low. The cardiac index is how good is their squeeze? How much blood are they getting to the periphery? And it's going to be low. So when we put in a Swan-Ganz catheter, pulmonary artery catheter, and we start measuring these things, it's going to be low. And then they're also going to have a high wedge pressure. And the reason they're going to have a high wedge pressure is because when you have such a poor squeeze, then the blood can't flow very well from the left atria into the left ventricle. So everything starts flowing backwards, which means your lungs start filling up with fluid. And when your lungs start filling up with fluid, you get pulmonary edema. That's going to raise those pressures up. So, essentially, this is all about it being a pump problem. The question is, where's the pump problem? So why would you have cardiogenic shock? Any type of ischemia to the myocardium that I like to think of it as a stunning. It causes a stunning to the heart. And that's an oversimplification because somebody who has severe heart failure, it's very easy for them to tip over into a cardiogenic stage, and that has nothing to do with stunning. But if you think of it like stunning, it means that you have depression of the myocardial muscles. So they are not getting the squeeze that they would normally get. So instead of being able to make a fist, maybe they can just move their fingers in just a little bit if you're somebody that can visualize things. So the pump's not getting the fluid out. Well, what are the things that we have to consider? Well, we have to consider preload. So preload is the amount of volume that we have in our right atria, but it also means how much volume do we have in our system. All right. So if we are overloaded with preload and our myocardium, especially that right ventricle that I talked about at the beginning of this adventure that we're on, if that gets stretched out, that causes some back pressure, that causes your CVP to go up, that causes your right ventricular pressures to go up. They're not going to get that squeeze because it goes all the way back to what we learned in nursing school with the Frank Starling law of our muscles can only stretch so much before they lose some of that elasticity, and then they don't get that contraction that they need to do. So there's that one problem. So that preload thing we would actually treat with diuretics if we can, if their blood pressure is tolerant. The other thing that we want to consider is what's the afterload, and so what pressure is the heart having to push against. So if you have this weak heart that's not getting a lot of squeeze, and you have a robust blood pressure, it may not be able to overcome the blood pressure to push the blood out of the heart. So then you just the cycle of hyperperfusion. So what can we do about it? Well, we have to think about what are the causes, and once we figure out about the cause, then we can optimize how we treat it. So we often see this after heart attacks, and when we see it after heart attacks, it can be a couple things. It can be the amount of tissue that's infarcted, so the amount of tissue that has died, or if that tissue has died around a papillary muscle. If you remember the papillary muscles are what would attach to the heart valves, and if one of those ruptures, then that valve cannot close efficiently, and you end up usually with a pretty acute mitral regurgitation. So that means every time your heart squeezes, your mitral valve cannot close. So the blood is trying to go out the aorta, but blood's going to go the path of least resistance. So it's also going to go back up into the left atria. And so it's not going to be efficient. You're not going to get good outflow to the rest of the body. I already talked about hokum a little bit, with sometimes the size of the muscle pushes the aorta valve out of the way a little bit, and that prevents blood from adequately going through. Aortic stenosis is a huge cause for it, and that's one of the reasons that we do a lot of aortic stenosis, aortic valve replacements, especially in elderly people, is because their aortic valves get very stenotic with calcium, and that causes a backflow. So your ventricle just cannot push against it. So some of these are a flat out surgical repair. The aortic stenosis is surgical repair. The papillary muscle rupture, sometimes they can go do a surgical repair. Cardiac tamponade, that's a little bit different scenario in that the fluid is sometimes blood or other fluid is collecting around the pericardium and it's suffocating them. So all you got to do is relieve that pressure, and that allows the heart to expand again and give that adequate squeeze, because before it couldn't fill enough to get the adequate squeeze. Other reasons, some of them can be just the tissue from a heart attack dying around there, and so you don't get enough squeeze in that area. In the neuro ICU, we see something called Takotsubo's cardiomyopathy, and that is also known as a broken heart syndrome when somebody has a profound pain like they do when they have a subarachnoid hemorrhage, or it can even be from a profound emotional shock. This is somebody who can actually have an instance of grief, finding out a father, a son, a child has died, and they have such a catecholamine relief that it literally does stun the heart and causes a cardiomyopathy there. Medications can also depress your squeeze. Pulmonary embolism creates a back pressure to the right ventricle and causes that cardiogenic shock usually on that side. It doesn't usually affect the left, but if it were to affect the left, it would be massive. So you can see there are lots of reasons for cardiogenic shock. So we got to think about, okay, what do we think the possible etiology is? I don't expect you to have to think about that with regards to the exam, but I would be thinking about things that we see like heart attacks and infarctions and stuff like that. And then how do we fix it? Well, where can we optimize the problem? We can optimize it by preload, getting off the extra volume if we can, if their blood pressure will tolerate it. We can do vasodilators. Vasodilators are something that actually affects your afterload. And if you decrease your afterload, I'm talking about maybe dropping your MAP down to 60. I know a lot of us think
Excuse
about
me,
a
Dr.
normal MAP
Nagel.
is 65. Yes.
What time did this review start at?
It started an hour ago, but it
Okay.
is being recorded, and I'm going to go until we stop.
Okay. All right. Thank you.
Yep. Vasodilators are going to decrease the blood pressure, and they are going to decrease the afterload, which is going to allow the forward movement of the blood. So it decreases the workload of the heart to get that squeeze out of there. We'll also consider things like epinephrine, which, if you think about it, is adrenaline, and so that'll get a little bit more squeeze out of the heart. Inotropes as well. Not only will they help with getting the extra squeeze out of the heart, they will also, they often have chronotropic effects, which means they can increase the heart rate. That can help as well. And then norepinephrine, this one gets a little bit tricky in how we use it. Norepi is something that we tend to use for vasoconstriction, right? We use it to help raise our blood pressure. Well, in somebody with cardiogenic shock, they're going to have a lower blood pressure, but we are going to increase that blood pressure to a supportive way, so we have adequate tissue perfusion, like to the kidneys and the other organs. And that will sometimes give us time to actually use things like Lasix and decrease the preload. So you want to optimize the preload, which usually means decrease the preload. You want to improve the function and squeeze of the heart, and then you want to decrease the afterload to make it more easy for the heart to continue pumping with as little effort as it can. For those that joined a little bit later, just a couple things. I'm jumping from different topics to different topics just so we can get a little bit out of each of the challenges from the test that you guys had. Also, if I don't cover something that you wanted more detail about, please toss a question into the discussion board. I will be happy to address it as I can. And then always, as you're going through, remember to think about normal physiology before we think about the abnormal physiology. So let's jump on to the RAS system. So this is one of the major ways that we control our blood pressure and fluid balance. It consists of renin, angiotensin 2, and aldosterone, and let's just walk right through it. So renin is released out of the kidneys, and usually it's released due to noticing decreased sodium, um, or it notices decreased blood pressure, decreased blood pressure or decreased perfusion in the afferent arteriole. Remember, A is the first one, so it's the one that's taking blood to the kidney. Or there's a sympathetic stimulation saying, hey, I need to have more blood pressure for this particular situation. So renin itself is an enzyme, and its only job is to take angiotensinogen and break it into a different molecule. That's all it does, and then it steps out of the game. Angiotensin 1 is not a molecule that's really used a lot in our system, but that is further cleaved into two different molecules by the angiotensin converting enzyme. And so one of those two pieces that are left over is angiotensin 2, and this is the one that is going to help us so much with blood pressure. Angiotensin 2 really is a very powerful vasoconstrictor, and by vasoconstriction, it increases our blood pressure. It also triggers the release of aldosterone from the adrenal glands, as well as vasopressin from the pituitary gland. Vasopressin in and of itself is quite a vasoconstrictive hormone in its own right. And then I will talk a little bit about aldosterone, because a lot of people struggled with this one on the test. So think about, always from this standpoint, think about what it normally does. So it's stimulated by angiotensin 2. It's released by the adrenals, and it helps regulate blood pressure by two methods. One, it helps absorb sodium, and when it absorbs sodium, it also absorbs water. Okay, so those two kind of go hand in hand. At the same time it's absorbing sodium and water, it is excreting potassium. So if you get a question of, hey, somebody has, hyperaldosteronism, what is that going to look like? Well, then you go back to what the normal is. It normally causes sodium to be reabsorbed and water to be reabsorbed and potassium to be excreted. So the patient should be volume up, they should have a higher sodium level, and the potassium should be low. Okay. Erythropoietin is also something that learners struggle with. So a couple concepts I'm hoping to tie together with this one. If you think about, or if you have dealt with people who have chronic kidney disease, the majority of the time they usually have an anemia that's associated with it. And so they even have a name for it, anemia of chronic kidney disease. But that helps me personally remember that this particular molecule is made in the kidneys, and its job is to stimulate red blood cell production. The way it does that, or the way it gets stimulated, is it determines that it's got a low PO2, pressure of oxygen. If it detects that, then it's going to start kicking this out. So how is it going to detect that, or what are some situations that it would notice that? Well, first of all, if we have anemia to start with, and then we have a low O2 carrying capacity because we don't have a lot of hemoglobin, that's going to be a signal to the kidneys to release this. Also, if you live at altitude, If you think about somebody who is at altitude, the oxygen level is still, it's an FiO2 of 21%, but the O2 molecules are actually farther apart, so people become more hypoxic at altitude. So if they live at altitude for longer periods of time, that can actually cause stimulation of this hormone. So things that are going to kick it in saying, hey, I need more red blood cells. So when we have damage to the kidney, as we do with CKD, then that can actually decrease the production of this hormone because the kidney is not functioning well at all. So one of the things that we can do, especially in our patient populations with end-stage renal disease, is they can actually get EPO therapy. They can get shots of EPO therapy. We can also do this for patients who have received cancer and they don't have good cell counts with their marrow just yet. One of the things that I want you to take home from this is that we can give them this as a medication. We can stimulate red blood cell production, but if we don't have the iron stores, the folate, the other things that we need, we may in turn give them a different type of anemia. So you got to have all the nutritional components together to make this function optimally. Ooh, and I spelled skeletal wrong. Now I'm embarrassed.
Can you hear me okay?
Did you have a question? There's a lot of background.
Yes. Okay, hold on. Let me switch over. Can you hear me now?
Yes, much better. Well, I thought I could hear you. Okay. Well, maybe we can circle back. All right. Hey, are you there?
No, she remuted herself. I'm watching her.
Okay. So sorry about spelling skeletal wrong. So hyperkalemia. So the things that we have to remember about this is it affects the conduction system as K goes through the membrane. So it affects your action potential. So when you have hyperkalemia, as we do in the clinical setting, that's going to be stuff we're examining in the blood, right? That's how we draw it. So it's going to be outside the cell, and that's going to in turn change the gradient and affect your ability for your cells to depolarize. So it's going to shorten the duration of the action potential. So if you'll look over here, you'll notice just how, remember, all an EKG tracing is the electrical pathway through the heart. Well, what is an action potential? That's part of that electrical pathway, okay? It's an electrical signal across the cell membrane. So you're going to have a change in your P wave. Your amplitude's probably going to get a little bit different. One of the first things that we see is what we call the peaked T waves right here. Just on a personal note, you don't always see those. So if you have somebody who has hyperkalemia, just believe it and treat them as such. But that's why we worry about it, because if we have a disturbance in the electrical conduction of the active potentials of the myocytes of the cardium, that's going to lead you to, that's going to lead you to having arrhythmias. And those arrhythmias can be AD blocks. It can be a sinusoidal node. It's dependent on how much that patient can tolerate and how high is their potassium level. All right, one of the other things that I actually got a lot of questions about in the discussion board was some of the hormones of hunger, and I just wanted to focus on two of them, hoping to make you guys give some tips to remember them. Ghrelin makes you grow. So when you're hungry, your stomach is going to release this hormone and get you to eat because you want to grow up and be big. It is an appetite stimulant, so and it's orexin hormone. Everybody seemed to get very fixated on orexin hormone versus anorexin hormone. They're simply names, and orexin it's going to be an appetite stimulant. Whereas if you look at the anorexin, which is the leptin, which there are others that fall into these categories, it tends to make you suppress your appetite. So ghrelin is made in the gastric fundus, so G and G helps me remember that. It stimulates hunger. It also actually helps control gastric motility, so it can slow down how you digest your food. Now, on the other side, leptin makes you lean. Don't totally swallow this 100%, but if it helps you remember that, that's great. One of the things you have to consider is, even though it is an appetite suppressant, one of the things that occurs is it's made in our adipose tissue, and as we become obese, we obviously have more adipose tissue, right? So that increases the amount of leptin that we have in our bodies, and so people start focusing on that and go, well, then I shouldn't want to eat, and I should have this appetite, suppressed all the time because I have more leptin. And also what occurs with leptin is it actually helps us tell our bodies, hey, I've got enough energy stores, we can go spend energy. We can go shopping with the energy. But what happens is, as we get more adipose tissue and as we develop more leptin, our cells can actually become resistant to it. And so we get into this negative feedback cycle where we actually don't respond normally to this hormone. We actually respond abnormally. The other thing that can occur with this hormone is it actually is a pro-inflammatory hormone and can cause you some damage from that standpoint. One of the things that I wanted to hopefully help some of these items stick to you is the glucagon-like peptide 1s. So if you're looking in your Pathophys book and you are reading the paragraphs about this, they delay gastric emptying, they suppress appetite, and they help you increase expenditure. These are the ones that are working for weight loss in America right now. So they have actually taken this molecule and they've been able to synthesize it. And not only does it help with diabetes because it's associated with insulin stuff, but this is how it works from a weight loss component of it. So just like I said back at the very beginning, you go ahead and start with what's the normal, what's the physiology, and then how does it become pathophysiology? And like everything else, a lot of this, once we figure out the physiology, then we can figure out the medications to assist us with, just like when it comes to our ACE inhibitors and our ARBs and stuff like that. It's all based on the molecular stuff. All right. ESR versus CRP. Go ahead.
Oh, in terms of the anorexins, like leptin, how when there's surplus of it, it becomes, you can get resistance to that. Is it true for the other two, like the glucagon peptide 1 and the aponectin, that you get resistance?
I don't know the answer. The only one I saw when I was doing my research was the leptin. That doesn't mean that you can't get resistance to the other one, but I can go look. I can find out for you.
Okay.
I'll put it in the chat. Not the chat, but I'll put it in the discussion board. Great question, by the way. All right, so let's look at some inflammation labs. So ESR and CRP are two of the inflammation labs that we use a lot. Literally, when we're doing an ESR, they draw the blood and they put the blood on the counter and they actually watch how the red cells drift to the bottom. So when you have an inflammatory process, fibrinogen comes in and causes the red blood cells to stick together. And so they're actually going to drop to the bottom of the test tube a little bit more quickly. The only reason I know this is because 20 years ago I was a lab rat as a phlebotomist, and I worked nights, so I know little things like this. This is, it's not a very specific test. It's a screening test. It's like, yes, there is inflammation there, but there's a couple things that you can do with it. It's definitely going to be prevalent in inflammatory like problems such as polymyalgia rheumatica, giant cell arteritis. Both of these are very related to the inflammation process. It will also be helpful when it comes to trending. Are these heading in the right direction? Are they not? C-reactive protein. This one is one that we like to use in the ICU, especially when we are thinking about somebody being sick, because we are going to see the levels rise pretty quickly, and so they're very helpful in telling us if somebody is in an acute phase or the very beginning of a problem. Those will be elevated. But one of the things about C-reactive protein, essentially, it is going to notice phosphocholine on the surface of dead and dying cells. And so it actually sends a flag to our immune system and gets it to kick in and get our macrophages to come and help out. I know this is a comprehensive review, but one of the things that I wanted to put on it is I personally have always had trouble remembering the difference between Crohn's and colitis. And so I just wanted to give you guys a couple study possibilities. Crohn's is something that can affect you from your mouth down to your anus. So your entire intestinal or ingestion system. And so the way I remember it now is Mr. Crohn has a mouth and an anus. And when you do a scope on these patients, they tend to have a cobblestone appearance to their intestines. So he likes to walk on cobblestones. Key things about Crohn's is that you're going to have healthy parts of the intestine mixed in between the inflamed layers. These are sometimes called skipped lesions. So you'll have healthy, diseased, healthy, diseased. Crohn's affects all layers of the bowel wall, not just one. And if you compare it to ulcerative colitis, and the way I remember colitis is it actually has part of colon in the word. It affects the innermost lining of the colon. It's usually continuous, so you're not going to have those skip lesions. And then oftentimes these patients will actually have bleeding associated with bowel movements. But taking it one step further, if you think about the purpose of the colon, the majority of the things the colon does for us is it reabsorbs water, right? So our nutritional uptake is going to be occurring in the small intestine and not so much in the colon. So when people have nutritional problems related to this type of stuff, it's usually Crohn's, not the colitis. Okay, I think that was my last slide. All right. What questions do you have that I can hopefully try and answer without looking like an idiot? Nobody? Nothing?
Dr. Nagel, I looked up the GLP-1 and you can become resistant, which is just such a bummer, isn't it?
Indeed.
That makes sense
Thank
though,
you.
because of all the people that go up on their Ozempic and all that.
I'm sorry, will this meeting be recorded for later?
Yes, it is recorded and we'll post it. And I'm going to beg Dr. Nagel for her slides. So all of it will be posted.
Thank you so much.
Hi,
I'm at
Dr.
work and I'm
Nagel. I
just
have
holding
a quick
on for a minute.
question.
For
I had a
Go for it.
question Can you go over scoliosis? Because I was a little confused regarding the degree of when would it be like clinically significant, when would it be mild? I know because the book had a different degrees compared to the outline.
Well, then go with your book, okay? Yeah, go
I
the
think I
text.
accidentally go with the book, but let me hold on, let me share again. All right, the book is going to be the definitive, okay? But essentially with scoliosis, mild scoliosis is usually, and you guys can see I reshared, right? You guys can see that?
No.
Oh. Hold on. All right, can you see it now?
Yes.
Okay. So mild scoliosis is a curvature of the spine of less than 25%. Doesn't usually require some treatment, although it might be recommended. Especially if you get closer to the 20 to 25%, because one of the things that they actually worry about, especially once you get from into the moderate scoliosis, is that those can actually continue to shift and cause some additional problems and some additional curvature. So mild is considered less than 25, moderate is 25 to 40, and that's going to be a combination of exercises, bracing, physical therapy, because they don't want it to progress into a further curvature. And then severe scoliosis is usually greater than 40%. And with those, you're definitely going to need some bracing. You're definitely going to need some exercises. And a lot of times they may end up going in and putting in some rods to help stabilize the spine. But again, I don't know if my numbers match the book exactly, but it should be pretty darn close. What else?
I have
Dr. Nagel. Oh, just real quick, on the scoliosis. So if we're talking about clinically significant, then that means one that we're actually going to be treating, right? So it wouldn't be mild. It would either be moderate or severe for clinically significant.
Yeah, I would say so, but I would also say that the other thing that you have to consider going forward, especially with scoliosis, you're going to be dealing with parents, and they're going to be absolutely terrified, and they're going to need reassurance. Does that make sense? So even if it is a mild scoliosis that will not require treatment, you are going to have to encourage those parents of it's going to be okay. These are things that we can do, but that's not necessarily something you have to do.
Sure. Okay. Thank you.
Who else?
Dr. Nagel, can you please talk about the serology interpretation for hepatitis? Yeah,
I actually have that. I know which ones you're talking about. I have that all written out in a discussion post. It's a lot easier when you can look at it. In fact, I'll re-highlight that and get that posted. I found a really good resource for you guys that talks right through it, and all I will do is, I promise I will do nothing but confuse you. So I will get that reposted for you.
Thank you.
What were the topics that were talked about in the first hour before we were informed that we were supposed to be on earlier? Was it just GI and renal, or were there some misconcepts that were before that? I mean, I got in on the cardiac and the cardiogenic shock, but I didn't know, because I don't want to ask questions for you to repeat.
First off, my bad for getting on early. I got my times mixed up because I got my time zones mixed up. And I jumped really all over the place. But you know what? If you have a question, ask the question.
Okay, I just was going to review the video, and those are really helpful for me. So I just didn't know if I knew topics, if it would help me to narrow it down.
Sure.
Yeah,
sure.
So
What
everything
I did
that Dr.
was,
Nagel discussed is it's all concepts that were tested and we didn't test well on. So no new concepts in what Dr. Nagel has reviewed. If that kind of gives you, some guardrails.
So Dr.
I
Nagel, I
can
have
go
a
real.
question about the oxygen dissociation curve. I've watched the videos, I've looked at it, I've watched other videos. Where in my clinical practice am I going to see the oxygen dissociation curve? Because I'm not familiar with it. It's not sticking in my brain because it's not something that I've ever had to use and apply to anything. So why does that matter, and where would we see it?
Fair enough. So we actually consider it a lot in the ICU environment, especially when we're trying. We have somebody that's on the vent, and we're having difficulty with oxygenation, or if we have somebody who is super sick, they have a lactic acidosis, or they have they've gotten a lot of blood products. All of those, it's not something that we pull out of the book and we go, oh, well, this is this and this and this, and this is how we're going to treat the patient. It's more of a theoretic thing, but we have to consider what are the things that are going to make it more difficult, especially in a shock type situation, to get the oxygen to offload to the tissues and perfuse the distal tissues. That's when we really have to apply to it. And it's not, we literally don't take and look out the curve, but we do have to consider what are things that are going to prevent me from offloading the oxygen to the tissues. Does that help?
Yeah,
I promise.
I think in my brain, like it makes sense to me that whenever you shift left or you shift right, that you're either you're leaving oxygen behind or increasing the affinity for it. But I was just trying to like figure out why and when we would use it, and how we would use it. Does that make sense? Like I'm predominantly ER. I've been ER most of my career. So once they leave me and go to the ICU, I don't know what they do. I just know kind of on my end of it.
We do a lot of magic with fairy dust.
I know you do. I've given a report to y'all.
So it's not something that we take out and we literally apply to a patient of, oh, we need to tweak this in order to get this. It's more of a theory based that we understand if somebody has a very acidotic pH, okay, they are going to have a lot of problem offloading their oxygen to the tissue. And so our job is to combat that acidosis, whatever it be caused from, be it hyperperfusion from a trauma, hypovolemic shock, be it a DKA type of situation. So we can get things closer back to homeostasis. And I think the best way I can put it is the farther off you are on the disassociation curve, the more critically ill that patient is. We will never use it for application of the patient, but it helps us understand the mechanisms behind why a patient is so sick and why they are refractory to some of our treatments.
Okay. That makes sense. Yes. Thank you.
You bet. Who's next?
I have another question, Dr. Nagel. So I'm getting a little confused between the differences for irritable bowel syndrome, inflammatory bowel disease, and irritable bowel disease. So it kind of like three of them, it gets me confused. Where, for example, we have like the Crohn's, ulcerative colitis, where it belongs, because on our note that we have, I feel like some of them are labeled a little, like there's a little confusion in there on that note. So can you please help me differentiate between the three?
So with regards to the Crohn's and the ulcerative colitis, the biggest thing is where you're having the damage occur. So with the ulcerative colitis, it's going to be confined to anywhere along the colon. Whereas with the Crohn's, it can be anywhere in the gastrointestinal tract, which is why you have those skipped lesions where you have healthy tissue in between. With regards to IBS versus IBD, I personally think of IBS as more of a syndrome of symptoms, which isn't exactly accurate. But the key difference is in IBD. So you're going to be dealing with inflammation. That's one of the etiologies. Whereas in IBS, it is not necessarily an inflammatory process.
Dr. Nagel, can you hear me?
Yep.
Okay. Just to add to that previous question, I think part of where some of us are confused is that in the notes, IBD is referred to irritable bowel disease and inflammatory bowel disease. Is there an irritable bowel disease, or are they referring to just irritable bowel syndrome and they just did a typo?
I would venture more of a typo.
Okay, thank you.
Well, so I know you guys got questions.
Yes, I was wondering if there's like pointers. I'm just having a little bit of a hard time with the blood flow of the GI system, because I know that it goes into the liver. I know that there's different types. Is there like ways that helps you remember?
I'm not sure I fully understand your question, like how it flows through the GI system.
Well, with the pathologies that are associated with it.
Let me work offline on that one and see if I can come up with a better answer for you. I don't have a tip off the top of my head.
Thank you.
Yep.
I have a question, doctor.
Go for it.
Maybe it's going to sound silly, but I'm kind of confusing spondylitis with scoliosis and the relationship with relationship to osteoporosis. If you can just maybe clarify for me so I don't confuse them.
That one I might have to look up a little bit, but I can tell you the basics. Scoliosis is going to be a deformity of the curve of your spine. Osteoporosis or osteopenia is related to decreased production of your bone tissue, which is over time going to lead to pathologic fractures and whatnot. And then the spondylosis, I'm not going to speak to that because I'm not comfortable enough, but I've written it down. I will give you an answer.
Yeah, can I help, Dr. Nagel?
Absolutely.
Primary care. I rock primary care, okay? You guys don't care about it, okay? So with spondylosis, spondylitis, anything that ends in a litis is going to be inflammation of, okay? Mm-hmm. So an inflammatory process in the spine, think of arthritis of the spine.
Okay.
That help?
That helps, yes.
Yeah, so two very different processes. Scoliosis, obviously, is arguably genetic and muscular, the foundation, whereas the spondylitis is, and can have different causes, autoimmune, etc.
Okay, thank you so much.
Who's next?
Hi, I wanted to ask if you could just kind of go over how cancer affects the telomeres. I think that I was just a little bit confused in that first part of our first exam, and it might be helpful
Sure.
if you could just explain it. Thank you.
Yep. All right, so you've got the telomeres, which are, I'm going to go back to sharing a little bit here. Let's see here. All right, you've got the telomeres. These are the end caps on each of your chromosomes. I want you to think of them like little shoelace cappers, okay? Every time a somatic cell, so a dividing cell, our body cells, divide, our telomeres get a tiny bit shorter. When we have divided so many times that our telomeres are gone, the cell can no longer divide, the cell will die, and it just stops at that process. Okay? So we have this molecule called telomerase. It is in all of our somatic cells, so all of our dividing cells, in small amounts. And it basically is a reverse RNA. And so what it does is it actually rebuilds some of the DNA in the telomeres. And so as it does that, it helps prevent telomere shortening. So your cell will divide a few more times than it would have without the help of the telomerase, which is amazing and would be amazing if we could, market it in great quantities. With the exception of, it's not found in youth, because when you have too much telomerase, that's when you start having prolific cell division, and that's when you start getting those cancerous tumors that are arising. It's just because there is too much telomerase leading to abnormal cell division. Does that help?
That helps a lot. Thank you so much.
Okay, Dr. Nagel, you've got some questions in the chat. Hormones secreted from the kidneys and their mechanism of action. Specifically, and you've already addressed erythropoietin to some extent. That was number 5 on the misconcept list. I don't know if you've got a slide for that one or not.
Let's see here. Trying to find it. The ones I specifically kind of spent some time going over were the was the renin.
Yep, you're good. That's what we're looking at.
Okay, hold on just a second.
I presume we're kind of talking about the RAS systems.
Well, looky there, I got a slide. Okay.
I knew you would.
So basically, renin is released down in the level of the kidneys at the juxtaglomerular. Oh my gosh, my mouth is done. The JGA, in certain circumstances. Okay, so one of those is going to be noting that there's decreased sodium in the distal convoluted tubulus. 2, and remember we talked about afferent arteriole is where the blood is going into the glomerulus, okay? So it noticed a decreased perfusion pressure in that particular vessel. Or there's a sympathetic stimulation, fight or flight. We need a better blood pressure for whatever the reason. Our body has signaled us that we need a better blood pressure. Okay, so kidneys release renin. Renin is a kind of little lazy molecule. The only thing it does is it takes angiotensinogen and it cleaves it. Okay, so angiotensinogen is made in the liver. All right, it's released into the blood. Renin is released into the blood. It sees angiotensinogen and it cleaves it in two. Okay, and it creates angiotensin 1. That is the product of what happens there. At that point, renin's job is done. It goes and takes a nap. It clocks out. It eats Cheetos. It's out of the program. Angiotensin 1 is now floating around in the blood. It's an inactive peptide. It doesn't do much, but then we have angiotensin converting enzymes or enzyme, and that cleaves that molecule and creates two other molecules, one of them being angiotensinogen 2 or angiotensin 2. That is your active molecule that's going to control your blood pressure. That's the one that causes vasoconstriction, which increases your blood pressure. It also tells your adrenal glands to, hey, kick out some aldosterone, and it tells the pituitary gland we need some vasopressin. The aldosterone is going to tell your body to hold on to salt and water, and by increasing the volume, by helping increase your preload, that's going to increase your blood pressure. What's next?
Next, we have antibodies in breast milk.
I did not address that one. It was on my to-do list. You will see
okay.
it in the discussion board.
Okay. Alrighty. And
but if anybody paid attention, I noted in one of the discussion boards that I had the measles when I was 9. I had been vaccinated for the measles, but I had the measles. And I was one of many children that year that had the measles. And it's all because we had immunobodies from our moms and we were actually vaccinated too soon. And so those antibodies went after our vaccines. Our vaccines never uptook, which is why we got the measles. And they actually changed the age at which children got their measles vaccines because of that. Mom's breast milk protects. Okay, what's the next one?
The next one is liver injury and acute liver failure. Was that? I don't think was that.
That was on my to-do list for a discussion.
Okay, very good.
I didn't see it on the list.
Okay, very good. And then hepcidin.
Hepcidin. Okay. I'll put a little bit more explanation about this in the discussion board. Let's see here. Hold on a sec. I started talking about it. Let me see if I can find it. All right. Hepcidin. Its concentration is regulated by iron, EPO activity, and inflammation. Let's see here. In chronic diseases, high hepcidin production inhibits the release of iron from macrophages and intestinal absorption of iron. Therefore, less iron is available when we have chronic diseases. And therefore, it can actually lead to some iron deficiency anemia. I've got this thing that's almost primed to put on the discussion board, but was there a specific question about it or just an overall?
I think it was an overall. Yeah, so that was just the concept. Yeah, the concept as it relates to iron was challenging on one of the quizzes.
Yep, and I've got actually a discussion post that's going to talk about TIBC levels, ferritin levels, and the hepcidin.
Wondermus. And you can draw a hepcidin level. And there's one more question about okay. in regards to ghrelin and leptin, can you go over what we would see in obesity in terms of appetite and satiety? Leptin being a anorexin, I know you would normally expect decreased appetite and early satiety, but since in obesity you have resistance to leptin, how does that affect appetite and satiety?
The way it's going to affect appetite and satiety is it's actually not going to recognize the satiety, and so you're going to continue to eat.
Okay, and then irreversible cellular injury and patient prognosis.
Yeah, I saw that on the list, and I wasn't quite sure how to address
that's
that one.
That's why I had that puzzled tone in my voice. Yeah.
Dr. K, can I interject real quick?
Uh-huh.
Quick question, just regarding the test review. I know you said that it was going to be 25 questions from the renal, 25 from GI, and then roughly you had about 25 so far for misconcepts. The other 25, just because we're coming down to the wire and it's so much information to get in, what is the best way beyond the misconcepts and the two last lectures? Is it just to read through each skeletal outline, or is there some areas that are a little more specific that we should be focusing on, just to kind of, because there's just not enough time to get all that information reviewed?
Yeah. So right now I have written 33 brand spanking new questions. Imagine my excitement. That are specific to the misconcepts on the skeletal outline, and I am sure that I can get the remaining 15 based solely on the misconcepts. And that kind of leaves poor renal and GI because we obviously haven't had those tests. And so won't know, where the areas of weakness are. But generally, I'm focusing around the areas of concepts that were challenging. And so please don't get too focused in on, the what we posted as the misconcept. Remember, concepts aren't questions. Concepts are concepts. So you want to think around, so Dr. Nagel just reviewed renin, and she reviewed the RAS system. She didn't just focus on renin. She didn't just focus on something else. She focused on the concept of the RAS system. So when you're looking at this, you're going to go astray if you're just looking at one component. You need to think about the concept. Okay? Which I know is not what you wanted to hear. I'm sorry.
Thank you so much.
I would also say, tomorrow I'm going to be spending most of my day trying to answer question for you guys. So if you guys got something you're stuck on, throw it on a discussion board. I really do try to break it down for you into essential components. Any burning questions?
There's a question about gender-specific diseases from the misconcepts. I believe that is more a genetic question. And I did not pull anything from the genetic skeletal outline. Okay, I promised you I wouldn't, and I won't. So now as you're treating patients, you know, in your nurse practitioner career, you're going to have to understand this stuff. So you need to go back and remember what you studied, but you didn't study for a test and pick that up. But I did not pick anything specifically off the genetics outline. Yes, I was gracious and decided that if I put so there's a question in the chat that says that the renal skeletal outline was almost nearly filled out in completion. Was that intentional? Yes, it was intentional. I put the preamble in that if you find errors, please let me know. I'm quite human, as you all know by now. So yes, I did that on purpose.
I don't have my notes in front of me right now, but I just had one other quick question just regarding the ascending loop of Henle. There's two things that I'm kind of getting confused about. It says in one spot, it says that it is water permeable, but then in another spot, it says that it is not water permeable. Apparently the thick, if I understand it correctly, it's only the thick part of the ascending loop of Henle is water permeable, but the thin, or sorry, opposite. The thin is water permeable, but the thick ascending loop of Henle is not. Is that correct?
I believe you are correct. Let me just double check here.
Because in our notes,
yeah, that's what it's looking like.
It is, but then like when I go on like osmosis videos, it never actually breaks it down between the thin ascending and the thick ascending. So then I just wondered if they do those, you know, two things differently.
Got it. You don't ask the easy questions, do you? Let me. The descending loop is permeable to water and impermeable to salt. The ascending thick to let me add this to my list. Yeah, I'm seeing a lot of discussion about salt and not water. The only thing I see is the descending loop permeable to water, but not salt. So let me find that out for you. Another thing to add for tomorrow.
And Dr. Nagel, there's one
Thank
more.
you.
I have to hop off for another meeting. But could you please explain bacillus avoiding destruction? Is that because there are endospores forming? Did you do one on this, Dr. Nagel?
I didn't, but I can explain it.
Okay, good. Okay,
Not a
great.
problem.
Yeah, because I was going to jump in there. Okay, bye guys. You're going to do great.
Yeah, so the bacillus itself, you have endospores that are embedded into the cell wall, and so because they're embedded in there, our immune system doesn't always see them, and so what happens is we actually get sicker after that particular cell dies, and when that cell dies, the spores get released into our bloodstream, and then they disintegrate and release toxins, and so we get sick from the toxins of the bacilli, not the bacilli themselves. The other thing I saw, somebody had asked, could you explain cobblestones and Crohn's? Just real quick, cobblestone refers to when you do a scope on somebody and you put the endoscope up inside them. The inside of their intestines looks like a cobblestone appearance, and what that is if you were to have a road that was made of a whole bunch of large rocks that are seamed together with a mortar. That's what a cobblestone appearance is like. And it just has to do with the inflammatory process that's associated with the disease. But that's not seen in ulcerative colitis. It's only seen in Crohn's. Anything else? Was this helpful for you guys?
Dr. Nagel, I had a question about the on polycystic kidney disease, if you don't mind.
Try it.
I was just kind of reading over the presentation after they get the Shiga toxin, and then had the D positive and then the D negative HUS. And it was saying that the presentation was that the HUS is preceded by the GI illness with diarrhea, and that D positive HUS occurs 1 to 2 weeks after the GI illness, but then the child's symptom free for 1 to 5 days. So do they have diarrhea in a period of where they're asymptomatic and then they start getting the clots in the kidneys, or is it completely asymptomatic and then it just all hits them at once? Hope that makes sense there.
Yeah, it does make sense. I don't normally take care of kids, so give me just a second here. I can understand the confusion. It should be a period of diarrhea, which is caused by the destruction of the red blood cells, and then they get better, and then they have the clots. But I don't want to lie to you, but it's because the diarrhea is caused by the E. coli. So yeah, diarrhea comes first. Let's see here. Okay, so let me back it up. All right, so your question is specifically when the hemolytic syndrome starts, or?
I guess I was just trying to figure out the progression of it. Like, so the child eats something, they get the toxin, it binds with the leukocyte and it goes to the kidney, forms a clot. But do they present with diarrhea for that first week, and then they're asymptomatic, and then 1 to 2 weeks later they start getting all the symptoms where their kidneys are shutting down? Because it also mixed in.
I believe that's correct, because you have the diarrhea that's caused by the E. coli. They recover from that, but then it's a thing of making the antibodies, which is going to cause the problems with the in the kidney area, which is why it takes that time in between the symptoms that you don't see. I'm not articulating well. Does that make sense?
No, it does. I just I've never done PD either, so I was trying to put some context to it.
It's okay. Let me add that to my list of things to put on the discussion board tomorrow. But yes, you should have the initial infection, you should have the recovery, and then you should have the new presentation of symptoms.
Okay, perfect. Thank you so much.
Who's next?
I have a quick question. From number 16 of our skeletal outline regarding the GI system and aging, under the pathophysiology, it talks about decreased energy needs, waning hunger, altered satiety control, but then in brackets it says high levels of ghrelin, and then also decreased food intake. So would you have high levels of ghrelin if you're having decreased food intake, or would that be leptin? In the notes, it says ghrelin.
If you have high levels of food intake, then your ghrelin occurs when your stomach is empty, right? So if you have high levels of food intake, it's going to decrease. If so you should have when somebody is getting older, they don't have an appetite, so they're going to have higher levels of leptin because that's going to be the satiety thing. I think, let's be honest, we've had a lot of problems with our skeletal outlines, right? So I'm going to go with that's wrong. Also think about, we have the aging anorexia. So that's going to be, they're satiated pretty quickly, so high leptin. They don't eat a lot. Their taste buds are messed up, so food doesn't taste good to them anyway. And because of their decreased muscle mass and everything else that's going on with the elderly body, their overall intake decreases. So the gremlin should be actually low. Thank you.
I know you probably already answered this question, Dr. Nagel. So, how does the GLP work? Like the Wegovy, what is the mechanism? How does it work? How does it function? I know it's glucagon-like peptide, but how does it work in the body?
Yeah, that's sure. It does a couple things. It delays gastric emptying. Okay, so it slows down how you process food, which means that you're going to be full for longer. All right. It suppresses appetite all over the place, so you're going to have a decreased appetite, and then when you do eat, your stomach's not going to empty as quickly, and then it also increases energy expenditure.
Is that the natural way glucagon works in our body?
The glucagon or the glucagon-like peptide?
No, I'm saying because I was reading this, maybe I was confused. It says that the GLP works like glucagon. So I was just trying to understand why they called GLP glucagon-like, and what's the difference between that and glucagon in our body?
Got it. It acts very similar to glucagon. It looks like glucagon, and if you think about the situations that you would use glucagon in, so we use glucagon in a fight or flight situation. So saber-tooth tiger comes out of nowhere, right? And we are stuck in front of it, and our body has to decide what to do, and so it kicks in the sympathetic system, right? So what's going to happen with the sympathetic system? We shut down our digestive system. Okay, so that's where you have the delayed gastric emptying and the appetite suppressant, because we do not need to be eating an apple while we're being chased by a saber-toothed tiger, right? And then also, glucagon is going to help us. It's going to give us energy because it's going to, turn into glucose. So it's going to give us energy so we can outrun the saber-toothed tiger. That's where your increased energy expenditure comes from. So it's very similar in that effect.
Oh, I see. Okay, thank you.
Anybody else with any burning questions? All right, well, I wish I had joined you guys a little bit earlier in the course, so this wouldn't be so much of a cram session. I've written down some topics to post to the discussion board tomorrow, so I'll get those up as I get those written. But I am serious. I am dedicated to you guys, you know, up through the exam. So as you have questions, please put them on the discussion board. I will do my best to answer them. Or, you know, I like to find like 3-minute videos that explain concepts. And then there were some things, what I may do is there were some things that I didn't cover in this thing that we did that I know I covered on the discussion boards. So what I may end up doing is just reposting some of those so they are fresher in the feed, especially like how do I figure out whether it's hepatitis or not, all the antibodies and how they work and whether it's current or recent infection or whatnot. Things like that, I'll try and do that. And then if I can come up with any other little things on how to remember stuff, I'll probably try and just post those as one-liners. This is a really tough class, and the fact that you've made it this far, you should be very proud of yourselves. Seriously. So congratulations to everybody. I know it doesn't feel like it. You're like, lady, we've got one more test. Shut up. But seriously, you've made it this far. This is a hard class. Hang in there. It's almost done. And the more you know this stuff, when I see you in acute care, you'll be like, oh, I got that. No problem. You'll get there. All right. All right. I'm going to sign out. But like I said, toss everything on the discussion board. I'll be looking.
Awesome.
Thank you.
Thank you so much.